Today we have brought both the Finance and Health and Human Services committees together to get a briefing on the State Innovation Model Grant, also known as the SIM grant, and to present on this $20 million grant that the state of Rhode Island got from the federal authorities. We have Elena Nicolella, Chief of Policy and Innovations, Office of Health and Human Services, and also the oversight of the State Innovation Grant. Elena.
Good evening. I was told I need a riser, so oops. Sorry, NPR. Okay, I'm getting off to a great start here. Oh, well, good. Good evening. Thank you very much for inviting me to come and talk to you today about our State Innovation Model Grant. As Senator Miller said, I'm with the Executive Office of Health and Human Services. We're the state entity that applied for the grant. And I should mention, though, it was in partnership with several other agencies, and I will highlight who those were, and some of the representatives from those agencies are here tonight as well. So I just wanted to give a little context for this grant. It is a federal grant. It comes out of the Centers for Medicare and Medicaid Services. When the Affordable Care Act legislation was passed, that legislation established a Center for Medicare and Medicaid Innovation. And it was part of the sort of two-pronged approach that the Affordable Care Act sought to implement. One was expansion and improved access to affordable coverage for as many people as possible, and secondly, to begin to transform and reform the healthcare delivery and payment system. So this grant is focused specifically on that second goal, which is the transformation of the healthcare system. So the problem that these innovation grants are trying to address is reflected in this slide, which comes from the Innovation Center. And it posits that today the historic state of our healthcare delivery system is producer or provider centered. So it's really focused on value to the either insurers or providers who are delivering services. It's very much focused on acute episodes and curing sickness. It's volume driven as opposed to value driven, clearly not sustainable, and people's experience of the care is fragmented. They need to go through significant administrative burden. Sometimes one provider isn't speaking to the other provider, not knowing that you may have had a hospital stay, et cetera. You're all familiar with these issues. The payment methodology is generally based on the delivery of a specific service that triggers a payment. And the goal is to move to this future state, which is very much more about the needs of the people that we're hoping to serve through the delivery system, more focus on preventive care, primary care, and it's really about a new value-based system so that payment is driven by improved health outcomes and by better value in the system. So the CMMI, the Innovation Center, has 7 categories in which they are providing these grants. And this is a busy slide, and I don't necessarily need to go through all of these, but those are the 7 categories. And I just wanted this slide to reflect the number of grants that providers or entities in Rhode Island have received through this Innovation Center. So all of those bulleted lines are recipients of grants. And this grant that I'm going to be talking about today falls under that last category. It's an initiative to accelerate the development and testing of new payment and service delivery models. Now, again, within that broad category, there are several different grant opportunities. This particular one, the State Innovation Model, explicitly asks what role can state government play in the transformation of the healthcare system. So a little bit of background to where we got to in terms of the grant that we have today. In April 2013, under the Lieutenant Governor Roberts' direction, the state embarked on a very intensive public stakeholder process where the Lieutenant Governor and her staff and other staff from state government convened meetings around the delivery system, around payment reform, around unmet need, and that all came about due to about $1 million grant that we first received from the Innovation Center, and it was for this planning purpose, and it was to develop a state health innovation plan. And this state health innovation plan is available, and I can get everybody the link to it. It's a very broad document. Many people in this room were engaged in that process. It's a broad document that highlights where we as a state think we need to address our healthcare system. So the next step was to take that innovation plan and then respond to the second opportunity, which was an opportunity to ask the federal government for dollars to implement some of the ideas that were in that state health innovation plan. And we applied for that in July of 2014, and just recently in December received the grant award for $20 million. And it's a 4-year grant period, and the first year is pre-implementation. So we can begin to get the resources we need to actually implement the changes. So we set out in the grant, and what I wanted to do today was tell you what the grant proposal has in it, what we've been approved for, but I do want to include a caveat that because of the change in administration, there is some flexibility to where we expend the dollars. So these are not set in stone, but this is what we asked for. So we wanted to take 3 foundational changes to state government in order to implement this grant. The first was that we wanted to work better within state government. So, for example, Dr. Hittner is here from the Office of Health Insurance Commissioner. She and her staff were very much engaged in the development of this grant. Dr. Michael Fine from the Department of Health, and from the Department of Behavioral Health Care, Developmental Disabilities and Hospitals. Becky Boss is here. She was also very much engaged. So the development of the grant was the model that we are going to pursue in the implementation of the grant, which is very much collaboration, much more integration. We want to be a lot more coordinated in terms of how we use our regulatory powers, how we use our policy-making ability, and our financing mechanisms. The second change that we wanted to make is we wanted to work differently with the private sector. So in past grants, we had used the private entities, commercial payers, hospital systems, primary care practices as advisors, but we wanted to change that model. So we developed the Healthy Rhode Island Steering Committee, and this is the committee that will make decisions about the way that the grant funds will be expended. So we had started off thinking that we would use private entities again as advisors, but we needed their buy-in to the goals and efforts of this grant. So we decided to come together as a partnership, a public-private partnership, to make those decisions. And some of the members of the steering committee are here. I see Steve DeToy. And this, again, the engagement of these organizations in the development of the grant in trying to convince the federal government to give us the grant was very useful, very collaborative. And then just the third foundational block that we were pursuing in the implementation is that we know that our ability as a state government to impact the delivery and payment system really hinges on our ability to access data, collect it, report it out, and analyze it. And our current capacity won't get us to where we need to go. So we need the tools to be able to measure the performance of this grant, and once the grant period is over, measure our performance in terms of overall healthcare delivery transformation. So with those three tools, we're going to meet the requirements of this state innovation model. The first requirement is that states need to develop a plan to improve population health. So the goal of the state innovation model is to think more broadly about what health is. So to not limit yourself, grantees, to the concept that you impact health only by addressing the healthcare delivery system, that you really need to be thinking about the way that people live their lives, whether they have access to healthy foods, whether they have access to stable housing, what the impact of poverty has on their lives. So with this population health plan, it's an explicit recognition of the impact of those non-medical, non-clinical needs on health. So one of the explicit decisions of the group was to be very clear that any plan to improve the health of Rhode Islanders needed to address their behavioral health needs. And we wanted to be very, very, again, explicit about this because of our unique, I think, needs in Rhode Island. So we are developing our population health plan with that focus on behavioral health care. These are the 9 areas that we are going to focus on in our population health plan. So it's a pretty broad range of issues. And what our plan was in the first pre-implementation year, we would use the steering committee to prioritize which issues we would address first. The population health plan, when it's done, will include not just measures and what we want to look at in terms of outcomes, but it will also include interventions and how we improve our where we are on those outcomes. The next requirement is the plan to reform the healthcare payment and delivery system. So the way that the grant was set up is first you develop your plan to improve population health, and then you directly link that plan to the way that healthcare services are delivered and paid for. So as a very simple example, smoking cessation is a priority for us. The federal government said every grant needs to focus on tobacco cessation, obesity, and I'm embarrassed to say a third focus area. It'll come to me. But so say it's tobacco cessation, and our population health plan sets out as a goal that we will reduce smoking by X%. We would want to translate that goal into the healthcare contract provisions in contracts that the state uses for Medicaid managed care organizations. We'd want to incorporate that goal into our patient-centered medical home initiatives. That's where we see the link. So we also, as a group, made the decision that we were not going to explicitly require providers to follow models. Some of the other states that applied for and received these grants said we are going to develop accountable care organizations or some other healthcare delivery model. And we were very conscious about not doing that because what we want to focus on is meeting the outcomes listed in the population health plan, as opposed to how the providers, commercial as well as public, meet those outcomes. So that's part of the discussion that we're going to have with the steering committee. We want to really balance the ability of the state to use, say, its regulatory, financing, and policy levers in a way that moves the system without being overly prescriptive. So I'm going to talk a little bit about where we are using the funding, and again, I include it in here just to give a sense of where our priorities are. The exact amounts may change, but this is where we think the money should be spent. One of the major components of our grant was that we wanted to take advantage of existing successful models. So many of you are familiar with the Patient-Centered Medical Home Initiative, the Chronic Care Sustainability Initiative. So we wanted to use some of the money to accelerate the adoption of that model in primary care. And the community health teams is an example of one of the ways in which we strengthen that patient-centered medical home model. The Child Psychiatry Access Program addresses the need to improve our behavioral health arena, and that program allows pediatricians to access child psychiatrists through the phone for consultations and support. Again, we have some monies put for explicit behavioral health transformation. That would be monies to community mental health organizations or substance abuse treatment providers to ensure that they are brought along in our transformation efforts. We also want to make a major investment in health information technology. So the first bullet there is the healthcare quality measurement, reporting, and feedback system. This is an effort to reduce the administrative burden on providers. So if you are a provider and you're working with 4 insurers, you may be asked to submit clinical data on certain measures in 4 different ways. So insurer A may be asking you to report on screening for diabetics in one way, and insurer B is asking you to do it in a different way. What this tries to set up is a tool, information technology, that would allow the providers to submit their data once and then allow insurers to access that data and use it for whatever payment reward system or incentive system that they have. So it attempts to meet the needs of both the payers as well as reduce administrative burden on the providers. Statewide Common Provider Directory seeks, again, to facilitate the need of different insurers and payers to know what affiliations certain providers have. So if I'm a specialist, am I associated with certain primary care practices? Am I associated with a hospital? And that's going to help us move towards this concept of holding providers accountable for the care and outcomes of their patients. Patient engagement tools seeks to ensure we have much more active and informed consumers. This could be reducing the need to fill out a form. Every time you go to a different provider, you still have to fill out a form that is all the same information that you just filled out last year. So this would seek to facilitate that. And the All-Payer Claims Database is an initiative that's already underway, and the funding would go to support and enhance that. One of the things that we have learned from other grants is that sometimes we don't take enough time to ensure we have the resources to implement. So we have a grant, but we don't have the people necessary to make it work. Where expecting people who already have full-time jobs to add grant implementation activities to that. So we wanted to avoid that with this grant. So we have some, in addition to in-kind support, we have asked, we have dedicated some funding to additional personnel to support the different state entities involved in this project. We would set up a project management office to, again, help with the delivery of the grant. The population health plan and behavioral health plan development, we would seek to contract out for that work. And then we have monies for the evaluation. So I didn't want to go too deeply into the grant, but I'm open to answer questions. So I do want to mention Senator Miller asked about another grants opportunity that came out after we had submitted our grant. It's out of the same innovation center. It's very focused on practice transformation. So at the provider level, ensuring that providers are ready for the transformation in healthcare delivery. So we've been working very hard to ensure that there is coordination and integration so that both grants support each other.
Questions? Senator Pila?
Yes. I noticed that the big aspect here, obviously, is partnership between government agencies and private industry, the private sector. But one of the things that you pointed out was the capacity to collect and store and use data. And being a data-driven type of person, I'm wondering, what is your starting point from this data-driven things that you're looking for in terms of when are you starting it, what type of things are you looking for, and can you elaborate a little bit more on that?
Sure. So the question is, what's our starting point? If one of our goals is to use data more to make decisions, are we starting from ground zero, I think is your question. So we are very fortunate that a lot of work has been done to set up an all-payer claims database in Rhode Island. And for those of you who aren't familiar with it, this is a very strong tool that all of the payers in Rhode Island have agreed to participate in. So all of the insurers are submitting claims data to this repository, and it's up and running. We're starting to get the first reports from this database, but what it will allow us to do is understand where the cost drivers are, how, say, state public payments compare to private payments, where there's variation in payments. It will allow us to understand the system from a cost basis. So that's already in place, and again, we'll be using the SIM grant funds to enhance and accelerate our ability to access that data. We're going to couple that with the in-state capacity to do overall evaluation. One of the things that we heard in the development of the State Health Innovation Plan was a need for the state to be more coordinated and to ensure that the initiatives we pursue were based on known problems, and that we were pursuing initiatives that addressed those problems, and we were able to say that those efforts resulted in success or they didn't result in success. And today, we don't have that capacity. So we would build within house off of an existing, potentially, we have an existing data warehouse in the Executive Office of Health and Human Services that has a lot of information from all of the EOHHS agencies, and it's person-specific. We have some challenges in accessing the data and also knowing what to do with it once we access it. So we will need some training and some assistance in just knowing what questions to answer. And so we've got the claims data, we've got overall state health health system data. And then we would also look to the electronic health records and start to explore how do we access not payment, but clinical data, and then in a de-identified way, how might we put those together so that we clearly understand the experience of Rhode Islanders and what the impact of our healthcare delivery system is on their health and well-being.
Would it also focus on certain types of, say, diseases or tendencies that people are experiencing? For instance, like asthma, for instance. Suppose we focus in on that with young children.
Yes.
And would we be able to do things like this with this database?
Yes, and that is one of the areas that we have a focus on in our population health plan. So again, the role of the population health plan is for us to really prioritize what we think is important. So for example, the health plan would include initiatives to reduce the burden of disease in children with asthma, and we would have data to tell us whether or not we were meeting those goals.
So, for instance, those 9 topics that you have would become a part of the database in terms of providing some sort of analysis as to where you're going with these certain things.
Yes, and the goal would be to be very public and transparent and accountable. So we will have as a public document the plan for population health, and it would list what our goals were in each of these areas and how we're measuring ourselves and what the outcomes should be.
Isn't part of, the effort, if you look at that list, is a focus on prevention. And if you're from the Finance Committee, the prevention is understood as a less expensive alternative to the outcomes without emphasis on prevention. And so that's something we've gone through, and it must be a major platform of the design of the grant. But I and many of us are aware that at some point when there was a larger grant opportunity initially, there was a focus on improving the primary care infrastructure through a community-based and a private-public partnership in creating a primary care infrastructure that was more robust throughout the state, that is designed to have the same type of outcomes, that the more primary care access there is, the more savings there is for public health system.
Yeah.
How much of that has survived the process?
So, there's a little hole in the middle of this riser. It's very exciting for me to be up here. Senator Miller is referring to a very painful aspect of this grant, which was we had asked for $60 million. And I don't know if CMS said, you have 1 million people, maybe that's an overreach. But so initially we had $10 million in an innovation fund, and we had monies explicitly around this primary care practice transformation. So some of it has we want to use the funds in a way to bring some of the smaller providers into the fold. So in order to be a patient-centered medical home as a primary care practice, it's quite an undertaking to meet NCQA requirements. And we have many 1 or 2 provider practices in Rhode Island that we fear are being left out of these transformation efforts. So we'll be using the practice assistants to do that. But the answer to your question really is this second grant opportunity, the Practice Transformation Initiative, and the Rhode Island Quality Institute will be submitting that. And that we are hoping will supplement what we had originally envisioned in our grant.
Thank you, Mr. Chairman. Elena, thank you for being here. 2 comments and then 1 more expansive question. If you can go to page, I guess it's page 7 on yours, page 6 on ours, with the list of the state government. Conspicuous by its absence is DCYF.
Yes.
I assume they're just Is there a reason they're not there, or it's...
No, that's a great question. It was not an explicit decision to not include them.
Any reason they're not there, given the cost issues potentially from a health perspective that population that we serve necessitates?
Yes. So a couple of points in response. The grant is explicitly not just about Medicaid. The grant is explicitly about overall healthcare system reform. We also are unable to, what's the word I'm looking for? Use the grant funds to supplant existing expenditures.
Right. So I'm not saying anything with regards to the state takes care of the cost for that, but if, as Senator Miller indicated, if there's a way to make that more efficient.
Yes.
Their kids, they have, as Senator Feelag indicated, they may have asthma. So if that population is not a part of it, there's a body of data we're not going to include.
So I guess what I'm trying to say is we should not assume that that population is not a part of this. The overall, the entity, the State Department itself was not engaged in the development of the grant, and whether or not a role for them exists in the ongoing implementation.
I guess I'd ask, given what's transpired there, given the new...
I think that's an excellent point.
Okay.
And
I'll follow up with you, because we show BHDDH there. Granted, they may have been involved with it. Shame on us that DCYF wasn't involved. I think they should have been. One other just comment, and it's the question back on your what you plan to accomplish. You have a fair amount of IT. I don't want to monopolize the time. Maybe I'll come back and ask you later about that. For anything from an IT perspective that's come before, I know Senate Finance or whatever, we have the Office of Digital Excellence. Tom Gerton, who's involved with the RIMS system over at DMV, Division of Taxation System, you name it. For the most part, he's involved with it. I'd encourage you to have Tom involved from the perspective of you need to figure out how to integrate 4 disparate systems, 3 disparate systems, 2, whatever, more than one, doing all the work up front. And it's going to be a lot of hard work up front to do that. Better to do it once now than come later on and say, yeah, we didn't do that then. We are where we are now. It's too hard to go back. So I encourage you to talk to Tom, and I'll follow up with him as well. But
yes, let's
fast forward to next year, 2016. And this is a 4-year grant. It looks like, based on what you're talking, you're going to spend about $5.3 or $5.5 million, if I add the numbers right, in this first year of the grant. When you come back next year to Senate Finance and Senate Health and Human Services, and the same folks are sitting here, what does success look like for you a year from now? Not 4 years from now, to know that we'd be on track to achieving the goals for 4 years from now? What would success look like in 2 or 3 or 4 different areas?
I think where we would want to be a year from now is we would want to have had the population health plan initial work completed, so that we were all in agreement about which areas we were going to be focusing on, what the interventions are, how we were going to look at the behavioral health, and to your point, for both children and adults, the transformation of that behavioral health system. So where we would want to be in January of 2016 is ready to implement that population health plan. So whether or not we would be ready with the impact at the provider level of that population health plan, I'm not sure. I think it's going to take us several months to come to agreement on what is in that population health plan. And again, we're using that as the guide to help us understand the effectiveness of our healthcare delivery system. By then, we should have a cohesive steering committee where everyone understands their roles and responsibilities, and we should have, along with this, a very public, transparent process. So we expect to be doing stakeholder engagement throughout the life of the grant.
One last follow-up. With regards to the folks that you're going to bring on board, project management and others, and this is under HHS, is it expected that you'll be leading this?
Yes.
Okay. Thank you, Mr. Chairman.
Any other questions? Senator Gold?
Thank you for the presentation. I have a question about just in terms of the data as we're tracking it. Are we also going to be tracking information about how other things that are not directly related to health, but things like decreased days of missed school because asthma has been controlled better with kids and therefore they're missing less school, or that less sick days or use of other services in the state that you might need for longer term care?
Yes, we are. And that, when I talked about the 3 sources of data, that is what we would hope that state capacity tool to use. So linking our health and human services data with the Department of Education. And where we would, where you would see that is our population health plan would say, let's continue with the example of children with asthma. If our goal is to reduce that burden, one of the ways we might measure that is in missed school days. So that would be one of the measures that we would report out to Rhode Island and say this is where we are on that. But the grant has a very clear recognition that it's not enough to just say the number of preventive visits that you've had. It's really about your overall health and well-being.
You kind of touched on where my question was going with as far as education. Was that RIDE wasn't on the list of people, groups that were involved, and I saw that Kids Count was, and I know that Kids Count is a great provider of data and analyzing data. But on the other side, I know, being in education, that schools are involved very often in the delivery of services. So there is a partnership with the Department of Education in terms of delivery.
Yes, so I regret not being a little bit more clear on this slide that these were the entities involved in the development of the grant. But this concept of working better within state government, being much more functional and high-performing, is not just limited to these entities. We would look to work very closely with the Department of Education and coordinate with all of the initiatives that are going on there, as well as the Department of Corrections. That is clearly one of the entities that we would look to reduction in recidivism as one of our successful outcomes. So there are many state entities, and this is really about a culture change, about not continuing to operate in silos, but really taking a person-centered approach at the state level as well.
Just one question with regards to the primary care physician. Are we believe that it would be a group of physicians, primary care physicians, that would be coming together instead of Dr. John Q, primary care physician by himself? Are we gearing ourselves more towards that, or are we allowing assistance to Dr. Q's primary care physician?
So it's a great question, and it's a question that I'm looking at Dr. Hittner, we spent quite a bit of time around this issue of how do we want to directly impact the way that providers deliver care? Do we want to go so far as to move the 1 and 2 provider practices? Do we want, through our efforts, to make them obsolete, or what do we want to do? And we made a very explicit decision that that is not the role. The role is to support those providers and ensure that they are part of the transformation and that they have the tools to transform their practices so that their practices are also very much patient-centered.
As I'd like to believe, we're going to be putting more and more responsibility on the primary care physician. Everything's going to kind of flow through them as far as the individual's health and well-being, more so than, say, a surgeon or somebody who has more technical care. So, but to take and to disown the individual primary care physician, I think we would be doing a disservice because, sometimes when we get bigger, we kind of lose the individual in the whole. And Mrs. So-and-so is no longer Mrs. So-and-so because the doctor doesn't know.
Yes, I think that we're very sensitive to that, and we have, as part of the Healthier Rhode Island Steering Committee, several representatives of large and then representatives of the small provider practices. So we want to ensure, we want to be disruptive in a very positive way. We don't want to be disruptive in a way that will hurt people. So.
Thank you, Mr. Chairman. Thank you for your presentation. A couple of thoughts occurred to me as you were going through the different slides. And in private industry, one of the things that we did was we looked at best practices, and we stole shamelessly from those best practices. Have you got some universe of other states or other organizations that have done this or are doing this? And have you gone outside of New England? Have you gone outside of the country? Like in Singapore, people's health records are contained on a credit card that they keep in their wallet, and it's got their whole health history. So if they get into an accident and they get hurt, it's all there. So are you going that far, or is this beyond the scope of what you're looking at?
So it's a 4-year grant, and the interventions that I've described today from a state perspective are pretty resource intensive. So I think, though, what we're hoping to do is use the funds in these first 4 years to develop an infrastructure that would allow us to maybe in that 4th year to start to take advantage, say, of what's happening internationally. I have been in conversation with the SIM director in Connecticut, and they just received their grant as well, so we're exploring opportunities for maybe some coordination of training, and they're a little bit ahead of us in terms of their activities, so we would look to partner with them. And 5 of the New England states have state innovation model grants, and we're going to look to work very closely with them.
Thank you.
I've already been approached legislatively by providers who are interested in accelerating the process that would lead to full integration of health records, electronic health records, and that currently people have either been sold or provided electronic systems that are not fully compatible with either governmentally or with other practices or other providers, either hospitals or smaller practices. And we're looking at potentially, as a legislative solution, creating a timetable for a compatibility. Would any of that work, or those concepts be some of what you are looking at also?
I think so. I think we developed this grant with enough flexibility, I think, to incorporate ideas like that. Again, it would be the steering committee that discussion and those decisions would be made, but that's exactly the kind of initiative that we would want to pursue in a integrated, coordinated manner so that everybody was aware of the impact. And we're hoping that this steering committee allows us, from a state government perspective, to do that.
Any other questions? Before we get back to Senator DePalma, I just want to state that I think the Health Committee has demonstrated by having this joint hearing that things that we deliberate on can actually save the Finance Committee some money, so I want to just point that out. Senator Ania.
Just I want to go back to something a little bit of what Senator Neal touched on. In your perspective on the very big picture of what is envisioned with all these grants, do you see the idea as seed money out there to these various states, and I'd like to have you chime in how many states are grants? Is the idea there's money out there now to help people brainstorm in their own markets so that ultimately we get the best practices, and the best practices developed in the best state that comes up with the best ideas translates nationally? Or do you foresee something where this is designed so that however many states receive them, it turns into everyone reinventing their own wheel? I'm hoping that there's a central end of the road process.
Yes, so it's a great question. The Center for Innovation is clearly focused on these grants as demonstrations. And as evidence of that, there were 2 rounds. The first round, I believe 6 states received implementation monies. And then the second round was the round where we applied for implementation monies. And just between that first and second round, the federal government changed the rules around the grant requests. So a clear distinction was in the first round, they said to states, if you're applying, we need to know that you're working with providers and the private sector. And you need to get letters of support from those entities because they will be impacted by your efforts. In the second round, they said, we need letters of attestation that these folks will be at the table with you, because their experience in the first round was some of the insurers or providers said, yeah, we're supportive of the grant, but when it came time to implement, they said, you know, we're not interested in playing in that arena. So that's a small example of how CMS, the federal government, has started to change what its expectations are. So I think their approach is, let's have, I believe it's 17 states now have these implementation grants. Let's see what's happening in each state. They gave us very broad guidelines. They said, we want 80% of your population to be in practice models that are not being paid on a fee-for-service basis. So 80% of the payments have to be an alternative to fee-for-service. They're looking for accountable care, but again, they're not prescribing the models. So I think it's a lot of different efforts and attempts within broad guidelines, and then at the end of the innovation period, we'll look to see what worked and develop those best practices. Because your point is very true. Some of these things are not going to work. They're going to fail. And we've been slow in developing accountable care organizations in Rhode Island. We have one with Coastal Medical in the Medicare demonstration program. But we don't want to be too hasty in trying out models to the point that you raised earlier. We want to be sure we know what we're doing and how it's going to come out.
Not to belabor the point, but I mean, the argument you made that the federal government will ensure the grantee should be a little short-sighted. This is the perfect state to do this. At 60 million a year, moving out of those 1 million people where things could be adjusted. You have a controllable market where the lessons learned could be translated to bigger populations.
Yeah, I think we can still get there with 20 million.
Senator Sheehan?
Thank you, Jim. I was looking at your presentation. Thank you for coming today. And you had 2 points. You had 2 points about a delivery system and payment transformation. So you're looking at this is slide. It's on page 3 for us. There it is. Volume driven to outcomes driven is the transformation that we would like to bring about, as well as fragmented care to coordinated care. Could you tell me, what does that mean? Are we talking about, for example, that a doctor ordinarily should be kind of what we'll call the quarterback of care for the individual to be, you know, people-centered, but because you have specialties, you kind of go into different people. And if you consider for a moment that, you know, maybe through insurance processes and other, you know, processes that are going on, they only have X number of minutes with each patient. Is that what you're referring to, that that doctor, that GP, doesn't really have the ability to piece together the puzzle anymore, so there isn't the quality of care, it's diminished? I mean, I can tell you from my experience, I find that's definitely occurring. Is that part of it?
Yes, that's where we want to go. So specifically, the volume-driven versus outcomes-driven. Instead of reimbursing a specialist or for several different tests or services that are provided. Instead, the reimbursement is based on how well that patient is doing in terms of not being readmitted to the hospital, for example. That's a common quality measure. So that transformation, though, is extremely difficult. And to be honest, there are entities that benefit from the existing structure. So it's a real challenge to move away from that. And what we're anticipating is that we use these federal grant funds to facilitate that transformation. So without these federal grant funds, we might move in that direction, but people would lose revenue. And is there a way that we can smooth that transformation and support that transformation?
And just a quick follow-up question, Mr. Chairman. When you're talking about, basically, I guess you're trying to create some type of performance measurement, some outcome measurement, would that include, and perhaps by way of suggestion include, not just what the doctors do, what the specialists do, but also, I think to be fair, include compliance in terms of what the patient does? I would suggest that be included in there, because if, a dentist, let's just say if it was dentistry, said, you have to floss and brush your teeth once a day, and the patient did not comply with that, the outcome might be negative, but that didn't indicate necessarily that the doctor had not done his or her job.
Sure. I mean, we'll look at risk-adjusted payment. So it's two things, really. It's not punishing, for lack of a better word, the provider for a lack of compliance on the part of
If they don't get paid, I think it's punishment enough.
Right. Yeah. So that's certainly something that we're sensitive to. And again, the benefit of having the steering committee is that we will hear directly from the provider community.
Okay. All right. Thank you. Thank you, Mr. Chairman.
Elena, just if I might follow up. If you can go to page 5, please, the next slide. So I started reading with interest, and I think it's called the Center for American Progress or something like that, where they talk about the accountable care states models. Yeah. And I know we first met up in 313 back in January of 2009, I think it was, talking about the Medicaid waiver. Yeah. And you weren't sitting on that side of the, you were on that side of the table or whatever, but wearing a different hat at the time. So I'm glad you are where you are. I think you indicated we're the bottom piece, right? Yeah. So there's several other innovation things moving along. One would believe that if I drew a Venn diagram of all of those, and however 7 or 8 of them, there's probably some overlap somewhere. Mm-hmm. One would like to think there's a fair amount of overlap to a bunch of them. So in the case of the reading about the accountable care states model and what Oregon's doing and what other places are doing, so you said earlier, we might have to worry about smoothing out the transition to the providers. I think if we look at it from this, I'm looking at it, it's in the middle, so if we look at this from a finance perspective, at the end of the day, the expectation is that you have quality care with the right outcomes. Mm-hmm. And doing that most efficiently, no one would want to not do that, right? So if we let's talk about the Medicaid side of things. Mm-hmm. In the case of DCYF and others, and if we wanted to get to 80%, 80% is going to include a fair amount of folks from a Medicaid perspective, right?
Yes.
If we don't do that, there's going to be a hue and cry to figure out how to cut that budget because it's just so big. We have a $200 million plus deficit. Not saying that this is where we should cut it. If we figure out a way to not only become more efficient, but also become more effective at the same time via these various innovation models, I think that's got to be the eye on the prize. That's the prize that the eye has to be on, from the perspective of whether it's an accountable care states model perspective and what, dare I say the word waiver again, and they're saying if you're potentially looking at a 5% savings, mm-hmm. they're targeting, and they're looking at them things from a contracting perspective of if it was $10 I was going to give you and you're doing it now for $9, you're going to share in the savings. Right. And if it's over, you're going to share in some of the costs. And get to a certain point, it's all you, but the waiver is there. So how do 1, 2, 3, 4. Is there 7? I guess there's 7 initiatives up there. 1, 2, 3,
yes,
4.
7 categories.
7 categories.
Yes.
Is there some period with which you or whomever, as the lead for the Rhode Island one, will collaborate with Coastal Medical and the accountable care states model that they're implementing, or the multi-payer advanced primary care program, to say, we're doing this, you're doing this, to ensure that, not that we don't want to duplicate. You might want to duplicate because you might figure out there's a better way to do that in the end, but how do you ensure that there's the right kind of overlap to show connectivity? And let alone, it's great with other states, but we have all this going on in Rhode Island. If we're not connecting it, shame on us. We always look at how do we share services across cities, and if we don't do it in our own city, shame on us. So is there a plan for
Yes.
interacting with those folks on a regular basis?
I think that that's a great question. So specifically on the accountable care piece, which many states have started to pursue in very active ways. So Al Caros from Coastal Medical is on our Healthy Rhode Island Steering Committee, very active and engaged. And we would look to him, and there are other ACO models in existence, just not funded through the Medicare demonstration. But we would look to learn from their experience and to spread that, as folks brought up, the best practices. So, for example, we are going to hear from Coastal Medical about challenges that they've encountered in integrating primary care and behavioral health care for their the people that they serve. And that will be a great lesson for us moving forward in trying to spread this concept of accountable care and shared savings, because you're exactly right. That's where we want to get to a model where there is an entity held accountable for that patient experience and the outcomes of that person.
One last piece, I don't want to belabor this. In reading through some of that, whether it's Oregon or some other places, through Medicaid, I think they're looking at certain, I'll use the wrong words, and respectfully it'll be whether it's certain medical conditions. I can't think of any right now. I don't think high blood pressure might have been one, or diabetes might have been another, but there were some that they want to say they're initially going to target on 5 or 7. Because in order to do that, you can then figure out how those costs will compare from state to state, organization to organization, as opposed to doing it all. Because if you try and do it all, it just becomes you can't eat the elephant in one bite. But if you look at some of those key areas and then drive those costs to provide the services that are needed at the right time, at the right place, for the right reason, you can get there. Is that part of what we're looking at as well in Rhode Island? We'll look at, and I know we have a full list of areas you're going to address. I think it'd be difficult to address all of those in any meaningful way and have real results at the end to say, okay, we're ready to take the next step, as opposed to what's the subset of those.
So I'll make 2 points in response. So the question about how is the Medicaid financed services, how will that be impacted by the State Innovation Model Grant? So because the OHHS is a single state Medicaid agency, Deidre Gifford is the Medicaid Program Director, and Elizabeth Roberts is now our new secretary. So we are expecting and assuming that the transformations and the new reforms would apply to Medicaid in the same way that they apply to other payers and purchasers of insurance coverage. So an example that's already in existence is our patient-centered medical home, and all of the payers contribute to that, including through the Medicaid managed care organizations. And that's the model that we would follow. The Medicaid population is very, very important to this effort because they represent some of the highest cost populations in our state. So a population-based health model necessarily requires you to address that 20% of highest utilization.
Thank you very much.
Any other questions? Hearing none. Elena, thank you very much. And I'm very happy to know that beginning tomorrow morning, Senator Miller will be downstairs with the Senate fiscal staff looking for savings. So with that, I would entertain a motion to adjourn. Thank the committee members of both committees for attending. Moved by Senator Palmer, seconded by Senator O'Neill, and Senator Satchel. All in favor? Aye. Opposed? Thank you all very much.